Welcome you to the Getting Removables webinar. It is being presented by Dennis Urban, CDT, and we will begin the webinar shortly. And now I will turn it to Dennis Urban, CDT, Director of Clinical Education, and now his bio. Dennis Urban, CDT, brings 40 plus years of dental technology field experience, including lab management, technical training, sales and marketing, product development, and quality assurance. In addition to being a seasoned dental lab manager, Dennis has been an eminent lecturer worldwide since 1985. His lectures and courses span many areas of dental technology, including denture setups, digital technology, denture processing, lab management, implant overdentures and bar design protocol, all on 4 and 6 case planning and chairside conversions, shade communication, occlusion, and soft liners. His technical articles have been published in publications across the US, Canada, and Europe. Dennis Urban has been president of both the Long Island Dental Laboratory Association and Dental Laboratory Association of the state of New York. He has served as a Cal Lab board member and is the current board president on the National Board of Certification and serves on the advisory board for IDT magazine. And he started all this when he was 5. So take it away, Dennis.
Okay. Thank you, Jessica. Man, I'm getting old. It's a lot of years. But thank you, everybody, for joining us tonight. Really appreciate it. And thank you, Jessica. And thank you for taking the time to really sit here tonight and listen to removable technology. As a removable technician for over 40 years, like Jessica mentioned, I'm very happy to share some exciting news on the technical advances in denture technology. And today we're going to have an overview on both printed and milled technology on digital dentures. And we'll also go through some of the important aspects of analog denture procedures. So let's start by going through the outline of the presentation. And there we go. That's me. This is me in Little Italy here. But again, over 40 years in dental technology, I had the opportunity to travel around the world, learn from dentists and dental technicians, visit laboratories and dental practices in Europe, Asia, all around the world. So it's been a really rewarding experience, and education is my passion. And I'm going to talk about what technology is evolving on the removable side, because it seemed like for years that we really weren't advancing that much in denture technology. We saw a lot of advances in crown and bridge, implants, zirconia restorations, and things like that. But what about us, the stepchildren of the dental laboratory business or dental business was the denture technicians. So we're really capitalizing on the technology now, and it's evolving really at a rapid pace. And we're going to go through some of that technology tonight. And as I speak, as talking about evolving quickly, there are some new innovations that have come out in the last month or so with digital technology also. So I'll bring you up to speed on that also. So we'll go through the reduction of chair time and adjustments on removals, digital versus analog full denture techniques, and case design with milling and printing techniques, communication with the dental laboratory, and leveraging digital technology to increase patient loads, meeting patient expectations in a realistic way, and implant solutions. We have a small section on implants. No, I didn't have that much time to elaborate. We only have and we have a lot of information to cover, but I will touch on a little bit on implants and effective communication and support between the laboratory and the clinician, and how to achieve case predictability, resulting in patient acceptance. So we come a long way, as I mentioned, with removable technology. These are George Washington's dentures on the top right-hand side here. We're made of lead and whalebone. And then we have these vulcanite rubberized dentures that were really popular in the 50s and early 60s. It was a rubber-based material, but the aesthetics were terrible. The fit wasn't bad, but the aesthetics were terrible. We've come such a long way with different materials also in the past few years. So moving forward, we come a long way with different materials such as denture-based acrylics, denture teeth, hybrid dentures, overdentures, digital dentures, and partial denture materials. We have a separate partial denture webinar that will be coming up in the future, so don't miss that. We'll talk about the technology with CAD/CAM with partial dentures also. But from here, we've come a long way. Now we have highly aesthetic teeth and unsurpassed denture-based materials. So we have dentures that don't look like dentures, and people don't want to look like they're wearing a denture. So we have these highly aesthetic teeth that look like crowns. The anatomy is great. The translucency is great. The shading is great with 3D shading and classic shading. So there's a lot we can do with these types of dentures to really come through on an aesthetic level. And then we can match the existing gingiva on a patient. This is a denture where the existing gingiva was matched on the patient. Look at this beautiful denture, full upper and full lower. We can denture-based stain and add these stains to mimic natural gingiva, which is great. And then we can mimic natural gingiva on the anatomy on the wax try-ins, utilizing artistry and various shaded waxes. And these are some of the photos. I don't know if I have them here. This is one of the photo of my my wax try-in. As you can see, I try to mimic the patient's natural gingiva. I add striations there, little veins, and different colorization at the periphery and the cervical. And I'd like to see have a patient see what these dentures are going to look like when they're finished. And this is what this does. We have a diagnostic wax up and crown and bridge. Why can't we not have a nice characterized wax up on the removable side? And there's another photo of a denture try-in that might work with the denture try-in and setup. So, and now we can print and mill accurate aesthetic dentures with amazing fit, form, and functions. And we're going to talk about printed technology in a little while. This is mill technology here. We'll talk about that. But where are we going with denture technology? Well, the United States dental laboratories are seeing a dramatic increase in full denture cases, implant dentures, and partial dentures. More income opportunities for dentists, dental laboratories, and dental material manufacturers are out there on the removable market. And more people need dentures now than ever before. The industry predicts tremendous growth now through 2050. And experienced denture technicians are the guides for dentist and patient success in denture prosthesis. And this is a quote from Dr. Stephen Wagner, who's a prosthodontist, really came forth and put his thoughts on printed technology for some successful technology also. And I heard this at a meeting a couple of years ago at Seattle Study Group meeting, Dr. Christian Coachman. He said, professionals who understand dentures are the ones who understand smile design. And I have to agree with that, because even on the dental technology side in a dental laboratory, I believe that a crown and bridge technician should know how to do a denture setup before they even get into building up ceramics. Because we have on an average a 40 millimeter intraocclusal space to fill. So we have to know occlusion, we have to know aesthetics, where those anatomical landmarks are, and it's really important, and a real qualified, experienced denture technician knows that. But we have a great challenge, analog versus digital. Okay, still, it's a very small amount that's being done. It seems like a lot. You're hearing a lot of hype and media, coverage on digital dentures, but it's still anywhere from 3%, 4% of the amount of dentures that are being done in this country. The rest is still being done analog, but we have to apply those same sciences from analog over to digital. But we have to move in the right direction. We have to know the technology of analog to design these types of cases. So we need preparedness, production, and profitability if you want to be successful in a digital world. So I have this little chart I put together here. You want to build the intelligent design platform with digital dentures and create a more personal and predictable service. And you can do that with the denture technology on the digital side. Engage your patients. We empower our technicians with this latest technology and reinvent productivity in clinical processes. So it's really important to do that. And you can optimize your operations and transform your digital offerings. And digital technology is great because, you send us the file, we do the designing and we do the production, and we always have that file on hand if anything happens. And we'll elaborate on that in a little while. But again, engage your patients. You can now deliver personalized, rich, connected successes with consistent, positive patient experiences with digital dentures. I'm all about getting clinicians and technicians in their comfort zone with making dentures. And, we'll talk about that too in a little while as far as remakes and chair time and more, and with less chair time in the operatory, utilizing digital technology. And we empower our technicians by keeping up with the fast moving clinical accounts, efficiently collaborating with our dentists and planning out these cases and anticipating and meeting customer demands. And to increase the flow of information across your entire operation in communication with us, you want to better manage your resources and keep your practice process synchronized across all boundaries. So you can expand the reach of your capabilities using digital channels, anticipate your customer needs, and understand how products are used, and quickly develop and improve your services and your practice with digital technology. But it all stems on communication. Communication is key in planning these cases. And, it's more important, I think, now than ever before, especially with digital and also with implant cases and implant technology. But I saw this quote also somewhere. It says the dentist should meet the mind of the patient before he or she meets the mouth, especially when it comes to removable cases. We have to have realistic expectations that we can put forth to the patient. And sometimes that's not done. So digital and analog, we still need to utilize the same fundamental prosthodontic processes to make digital dentures as we always, to make a digital denture as you always have. You know, the clinician still needs to communicate and provide the technician with the necessary information for a functional case. And digital technology is still evolving, like I mentioned before, and it's improving at a rapid pace. If you asked me probably 2.5 years ago about printed technology, I would just shake my head no. I didn't want anything to do with it. The material was brittle. It wasn't aesthetic. The bond wasn't great with the denture teeth, and it didn't look it didn't look great. It wasn't that functional either. But we've come such a long way in 2 years. I want to show you some of the technology in a little while. And the basic knowledge of prosthodontic principles, including providing accurate impressions, is even more important in the digital world because many details now can be seen on a large screen, which we could not see before. And dentists still need to understand the importance of capturing accurate maxillomandibular records, vertical dimension, and centric relation. And dental technicians need to continue to analyze ridge relationships and then select appropriate anterior, posterior, and posterior teeth for the desired occlusal scheme. And this all starts with a preclinical interview. And you ask the patient these questions, and it's a great way to get started and evaluate what the patient needs and what the patient anticipates and meeting their needs in a realistic way. Ask, what are your specific concerns or limitations? How long have you been a dentalist? How many dentures have you had since your tooth loss? And how did you lose your teeth? And when was the last time your dentures were relined? How many stories do you hear of patients just wear their dentures for years, 5, 7, 8 years, without having it even checked or relined? You know, this could cause great atrophy through the ridge. And how have you ever considered implants? Maybe that patient is a good candidate for an implant overdenture or a hybrid type case. And the denture checklist. Check that patient complaints, their history, like I mentioned earlier. What kind of support did they have with their existing dentures? Were they moving around a lot? Was there any retention? Did it create sore spots? What about the occlusal scheme? Was it lingualized occlusion? Did they have centric occlusion? Was they have flat plane teeth? Did they have a good functional 20-degree or 30-degree tooth on previous dentures? And then we have to look at the floor of the mouth and tongue room for position. And I always make this a point to teach when I'm teaching hands-on courses too, when we're designing dentures, make sure we have enough room for that tongue so the tongue doesn't trip out that denture and the patient can speak easily. We also have to check border extensions, centric relation, VDO, of course, phonetics and aesthetics, occlusion, and the opposing dentition if we're doing one arch at a time. So we talked about earlier about communication. You know, we have all these communication tools at our fingertips, and sometimes we just can't plan a case correctly. So it's really important for us to collaborate on these cases and to bring forth a successful case that's going to be beneficial for the patient and also help enhance your practice. So communication with the clinician, we depend on your clinical knowledge and training, the assessment of the patient, the appropriate treatment planning, detailed information on the work authorization form. You know, we like that detailed information with digital photography. And we want the use of quality materials for a good outcome of the case. And communication from us, the certified dental technicians, we depend on our technical expertise and knowledge of procedures and materials. And we give you the appropriate feedback on impressions, bites, shades. And I think the number one call we still make in a laboratory is on impressions, and then bites, and then the shade. So it's important that we do case planning with you in the correct way. And we love to have that digital photography, because if you're using the right tools with a semi-adjustable or fully adjustable articulator with digital photography, it's like having the patient at the bench with us. Because like I mentioned before, we have to fill that big void with denture teeth. We want to make sure we're doing it the correct way and with good function and aesthetics. And of course, we want to use the quality materials that are necessary. So let's look at growing dentalism in this country. More than 36 million Americans have no teeth, and 90% of those have dentures, the ones who have no teeth. And 90% of denture patients aren't unhappy with the fit of their dentures. That's amazing. You know, so that's why it's so important to really get a case that's going to be functional, and one that's going to be aesthetic, and one that's the patient's going to be happy with. You know, and I have this picture here. Every time I go to Chicago and come out of O'Hare Airport, it's a sign going down to downtown Chicago. It says, "Don't die with your teeth in the glass." and a lot of people, that's what they do. They throw denture teeth in the glass, they put it in when they want to smile or talk, and even that is not functional sometimes. So we want to make a good case that's going to be functional and aesthetic. And some of the denture challenges for the clinician is, dissatisfied, frustrated patients. Difficult to provide a good fitting denture and long turnaround time. If things aren't done correctly from the onset, you have a lot of resets, a lot of chair time, a lot of operatory time. And after all that time has elapsed, how much money are you really making and how happy it really is the patient? So significant chair time reduces your return on investment, as you all know. 5 to 7 appointments to see the final denture. On an average is 5 appointments. 3 to 4 appointments sometimes to adjust dentures for sore spots. And then marketing price pressures also. So let's just touch on some of the problems with full dentures. We have compromised stability, poor neuromuscular and coordination due to bad occlusion, the low tolerance on mucosal tissue for a removable acrylic basis, especially on a lower denture, and patients' desire for more stability and comfort. And the comfort level of the dentist is compromised due to excessive chair time. I was on a phone call a few days ago, and I was speaking to a doctor, and he said, "Dennis, I hate doing dentures." I said, "Why? Why do you? I've been so successful with dentures over the years. Why do you hate doing them?" Because it's just I'm married to the patient. I have nothing but adjustments. It seems like every case is a problem. And I said, "We have to sit on one of my seminars and one of my hands-on courses. We can correct that for you." So we want to raise that comfort level. And with digital technology, the predictability is there because of the software and the accuracy of the impressions too. So what about the goals for a final outcome? We want to create natural aesthetics, enhance facial appearance, compensate for that lost soft tissue, and enhance that function with the right occlusal scheme. It could be centric occlusion, physiological centric occlusion, lingualized occlusion, whatever is comfortable for the patient is going to be beneficial for long-standing success of this denture. And create a denture, like I just said, longevity, impact resistance, and bacteria resistance. A lot of times I ask doctors and attendees at my seminars, does everybody know the differences between denture teeth, or the differences between denture-based materials in the market? And a lot of people don't know that, and we want a denture-based material that's going to have impact resistance with flexible strength, and with the high impact resistance, bacteria resistant, and then you want a denture that's going to bond well to the denture teeth, so you don't have to worry about teeth breaking. And the denture teeth now, it's made so well, and we're going to talk about that in a little while. But any elimination and reduction of adjustments on occlusion and sore spots. Some of the common mistakes in fabricating full dentures: poor treatment planning, distorted impressions, inaccurate master models, insufficient occlusal records, and the poor choices of materials. There's another lecture I do is called Excellence in Denture Technology, which covers in depth a lot of these things that I'm talking about tonight. But tonight we're going to touch on digital and comparisons to analog. So let's talk about the best practices on full dentures and the traditional way of doing things. Well, traditional clinical protocol for removals is about 5 visits. And we talked about that earlier. We touched on that. And the first visit is a preliminary impression. Second visit, we make that custom tray so you can get that final accurate impression. Then we'll send a bite registration for occlusal records for the third visit. And that fourth visit, we're going to send you a tooth setup with the wax try-in. And the fifth visit is you do that final insertion. And a visit can be eliminated if a functional impression was taken inside the occlusal rim, at the time of when you're taking the bite, and then a bite registration is taken at the second visit. So you're eliminating 1 visit. You can cut this down to 4 visits if you take an impression inside the occlusal rim with the base plate. So first visit, you want to get a good preliminary impression because, if you capture all the anatomical landmarks in a preliminary impression, chances are you're going to get a nice final impression because we're going to make a nice, accurate custom tray and make sure all those anatomical landmarks are captured in the impression. The second visit, you want to get a good custom tray impression with border molding. And we want to make sure all those borders and anatomical landmarks are captured in the impression, including the retromolar pads, hamular notches, and frenum. And this is also something that we need on the digital side. So we'll talk about digital technology as far as scanning, intraoral scanning on fully dentulous cases in a little while, and how far that's come in technology. But border molding is important, so there's a number of ways you can do this. I recommend, putting adhesive on the borders using a heavy body or monophase material, putting that tray in the patient's mouth and have them move their cheeks and talk a little bit, smile and have frown and capture all that musculature in the mouth. and then take that out of the mouth and come over with a light to medium body material and get a good, accurate impression. And this is compound. You can use compound for border molding also. I see a lot of doctors still doing that. That's fine. You know, I kind of I got used to the polyvinyl material over the years, so we utilize that a lot. And something like this, a nice border molded tray. And then individual trays with bi-rims. This is what I talked about earlier about eliminating a visit. So what we'll do is make a custom tray. And you see, I went a couple of millimeters short of the periphery when I made this tray, so you can border mold it. So you take a nice functional impression, and then you can take an occlusal registration at the same visit. And then we'll pour a model. We'll mount these on a good semi-adjustable articulator or fully adjustable articulator. And then we have to make new base plates and set up the denture teeth. And we'll go through that in a minute also. So these are the master models with a functional tray and a functional impression, which is great. You know, saves a visit, saves a little time. And here's a nice functional impression, as you can see on the tissue side. This doctor liked to do a nice full border on these types of full roll in these cases here. So we captured a lot of the full roll, captured all the anatomical landmarks, hammer notches, post-am area, and retromolar pads and periphery. So the bite registration using this functional impression material with therapeutically designed bite rims is one of the most reliable ways to transfer that oral situation to the articulator. The other way to do it is with a face bow. I don't have time to talk about face bows tonight, but it's funny. Every time I do a lecture in person, I mention face bow. Everybody kind of backs off and gets afraid, and they're intimidated. But you know, that is a great way to, especially with full mouth reconstruction, to get the information we need at the laboratory to give you a denture, full upper, full lower denture, or restoration that's going to probably eliminate a lot of adjustments because of mimicking that true jaw function with a face bow transfer. These are beautiful impressions right here. We have nice full borders here, a little thinner than the other borders, but we captured all the anatomical landmarks. And this is an inaccurate impression. We have pressure areas with probable overextension on the border areas, loss of detail from excess saliva. And you can see that tray showing through the impression material here. And at this point, you know, if you see something like this, I would say take a new impression. First of all, grind those areas away where you see showing through the tray, and take a new impression where those tray is showing through. If I got this back at the laboratory, first thing I would say is, man, this is going to create sore spots and something that's not going to be stable for the patient. So I would probably send it back, and I'll make a new custom tray and send it back and ask for a new impression on this. And then again, you have a sulfur impression here. You know, it's this infragum type impression, which is nothing wrong with infragum material, but a lot of times what happens with on a full denture, it kind of compresses the tissue a little bit. It's a little too heavy, you know. So I like to get something with a medium or light body when you're taking a fully edentulous case of impression. How about this case here? This is an actual case I got in the laboratory. I feel so bad for this patient. This patient must have swallowed, put this halfway down to his stomach, this impression material. And the patient was probably laying back in the chair and just went down his throat. And, you know, something like this, we sent this back to the doctor. Actually, we made a new custom tray. But you can see in the second picture here, on the anterior section here at the periphery, nothing was border molded. You know, you have this tray showing through. We have all that excess material that just went all the way to the posterior part of the patient's mouth. And something like this is really going to be a problem. So what about intraoral scanning on full arch cases? Well, I get that question asked a lot. And scanning is possible, but it's still not perfect. You know, additional steps must be taken, and case selection is critical. You can use an indelible pencil to help with stitching issues when scanning a particular arch where there are very few landmarks for reference. I see this a lot, you know, with this indelible pencil. And cases with tissue texture and landmarks will be easier to scan well, and we must make sure they capture all those landmarks. You know, so on cases where I see this all the time, on cases with really bad undercuts, or a patient has limited amount of room for intraoral scanner, it's difficult to capture all those landmarks. So, you know, there's some techniques that have been successful. We're going to touch on that now, and some of the studies that have been out there. And one of them is from Dr. LaRussa, and he did an edentulous scan strategy, and he designed for optimal scan experience of edentulous patients with 3-shaped trios. And he had a kind of a directional system that he used. As you can see here on the left-hand side with this upper arch here, he went from the one hymenal notch on the right-hand side all the way to the left. Then he scanned the palatal area. Then he went around the periphery, and he got really accurate scans all the time. He gets one accurate scan after the other. And the same with the lower. Look at the directional scan he has on the lower. On the retromolar pads on the buccal side, and then, on the lingual side rather than going on the buccal side, and vice versa. So he's been very successful with this study. And you can check out this study online. Just go to punch in Professor LaRusso, and he has a great study that he did with trios. There was another study that was done for the Journal of Prosthodontic Research, and that was in February in 2020. It was an in vivo feasibility study with computerized optical impression taking of a dentureless jaws on 29 patients. And their conclusion was, within the limitations of the present study, the investigative scanners were not able to currently fully replace a conventional impression for the fabrication of a complete denture. But look at their directional impression. They went in a completely different direction. They were going back and forth across from one side of the ridge to the other, and they weren't getting accurate impressions. So maybe if they used Dr. LaRusso's technique, they would have gotten more positive results on this research here. But we'll touch on that in a little while, as far as digital scanning. So how we have a nice accurate impression and a occlusal rim. We're going to get the bite registration and occlusal records on the third visit. So I want to make sure the patient is in an upright position. We're going to try to contour this occlusal rim as close as possible to the patient's oral anatomy. Make sure there's no interference with the wax. And if taking the occlusal records for a full upper and full lower denture, place feed cuts in that wax in the posterior regions, and then place bite registration material between the both of them. And at this point, verify the shade with the patient also. You're going to be taking a shade at this visit also. And if possible, if you have a living mold guide in the office, you could possibly pick out those anterior teeth. So it'll help us too. And what we do sometimes also, we'll actually set up maybe two to four teeth on the anterior when we send the occlusal rim. This way you can give us the information that we need. And it's really important, even with digital dentures, to give us this information on the occlusal rim, including the midline, the canine line, the smile line, and the approved occlusal plane set. So it's really important that we get that information. And if there's existing dentures that are you can eliminate another visit with taking a wash and a bite registration in the existing dentures if they're in good shape. So this eliminates a visit also. And we see this quite a bit on the digital denture side, where the doctor will take a wash impression, or even with border molding on existing dentures, and take a bite registration, scan it in the office, and then send us the STL file and eliminate 2 visits right there. So we can get you a denture in actually 3 visits with this particular scenario. So we have that great occlusal record that you sent us, and we're ready to do the tooth setup for trying. And at that point, we're doing a setup here. These are some of my setups I showed before. Check for occlusion, phonetics, and the shade, and make sure those aesthetics are pleasing to the patient. If the patient's not happy, as you know, nobody's happy. So let's talk about setting teeth a little bit. And we'll talk about analog denture setups. I'm not going to go into too much detail. There's not enough time tonight. Matter of fact, let me check my time here. Perfect. So, denture setups the traditional way, they take a lot of time. You really have to know what you're doing. I see a lot of technicians as I train across the country in different labs. They throw in teeth in the wax, and a lot of times they don't know the science behind what they're doing. So it's important. So I like to utilize semi-adjustable or fully adjustable articulator, something that's going to mimic true jaw function. With like an intraocclusal space of maybe 110 millimeters or more, that'll be great. So we put this on the articulator. What we'll do is line up the models the correct way. And I actually take a rubber band and put it on the incisal pin. There's a little slot in the incisal pin. And most of these semi-adjustable articulators and fully adjustable articulators have those little notches on the posterior region. This is your camper's plane or plane of occlusion, and you can set those models perfectly when you're articulating these cases. And this way we can mimic that occlusal plane that we need. Beautiful articulation here. We're setting our denture teeth. I usually set up the upper anterior teeth first, then the lower anterior, and I talk upper posterior and then lower posterior, then I go upper and lower, and I finish it and I check my working and balancing. In this particular case, you see the lower setup here, and the upper teeth is set to the lower. Yes, a lot of technicians do that. A lot of people set their teeth that way, but now we're ready to wax up the case and ready for your try-in. Go, nice fully functional case. This is your wax contour for the try-in I mentioned before. And what about that case I showed you before, that functional impression that was taken and then the occlusal rim was taken at the same time? Well, we can't utilize that base plate anymore. It's too loose. We poured a new model. We had the base plate material, and it's going to be too loose to try in the denture. So we have to make another base plate. But we don't want to lose the information we had on that occlusal rim. So I usually make a putty index of the existing occlusal rim. I know exactly where the anterior teeth are going to wind up. As you can see here, I got the midline, the cuspid lines, and I set those anterior teeth right to where they should be, the information that the clinician gave me. I have my centrals, laterals, and cuspids, and I set my lowers to follow the guidelines of the loppers, and I set my posterior teeth. So then we have, after the setup is done, that fifth visit, if the setup was satisfactory, then on that fifth visit, we're going to send the final denture that's processed, and we're going to check for fit, form, and function, check for pressure spots, and equilibrate that occlusion. So there's 5 visits on an average. Like I mentioned earlier, there's sometimes just 7 or 8 visits. So we want to make sure, but if everything's done correctly, like I just showed, we don't have any guesswork. And if there is a problem, we stop that case on the onset rather than having a remake, we're in good shape. So these are some of the best practices with traditional full dentures. And I mentioned before, I just want to touch on denture teeth a little bit here. As you can see, these teeth on the upper right here, on a lingual, they have lingual anatomy. And a lot of denture patients, when they get their full dentures, the teeth tends to slide off the lingual of the denture teeth, and it takes them a while to get used to it. So I try to utilize denture teeth, but lingual anatomy. It increases it forces better phonetics. And then I also put a little rugae in there. Sometimes I'll mimic the patient's natural rugae with a wax impression. I'll put that into the palate, and I'll process it with the patient's impression of the patient's natural rugae. So all these things taken into consideration produce a successful case. So let's do a comparison here on the workflow from traditional and printed, and we'll get into some of the digital technology in a minute here. So traditional, I mentioned earlier, we have 5 visits. On a printed digital denture, if you take a wash in the existing denture and scan the impression and bite on the first visit, it's only 3 visits. So the second visit, we'll send you a printed try-in. A little bit different now, the printed try-ins than what you're used to seeing. You saw my try-ins earlier. This is going to be a little bit different. It's more of a monolithic shaded try-in. And then we give you that printed try-in, and on the third and final visit, you insert it. So we can cut that 5 visits down to 3 visits in a very successful way. A little picture here, just scanning. We talked about scanning before. It's so it's great results with doctors scanning the fully dentalist patients with wash impressions and scanning the bite. And it send us that STL file. You can give the denture back to the patient, and we can start designing the digital denture, which is great. It's thanks to Dr. Ben Oppenheimer for that video. So the next step on a printed, we're going to have to do a printed try-in. So you sent us the information with the scanning of the bite registration and the wash impression. So this is what the printed try-in looks like. And you can see I added some wax on the anterior section. I can get crazy with the wax up too. I can make this look real natural. And now there's, in the future, you're going to see that these printed try-ins are going to look really natural. The only thing you can't do is start moving teeth around, because it's in one piece. It's a printed monolithic type of material. And so when you try this in, want to make sure that the aesthetics are pleasing to the patient. If the bite is off, you can grind the teeth down. You can take a new bite registration. If the midline is off, just mark it. And what we'll do in the laboratory, when we get it back to the laboratory, we'll rescan it and merge it with the original file. So there's your printed try-in. They don't look too bad, not bad. But any adjustments that have to be made, you can make them. And again, if it feels too loose, you can also take another wash impression, and we can rescan that and merge it with the original file. So if you're not doing, working comparison with a brand new denture, if you don't have an existing denture to work with, and then you're still going to do pretty much a 5 visit denture here. So preliminary impressions are going to be taken for custom tray, bite registration, then the 4th visit is going to be the printed try-in, and the 5th visit is going to be the final insertion. So let's talk about fabricating a printed denture. We're going to talk about a couple of systems tonight. I don't want to be biased because there's a lot of good systems out there. We're going to talk about Dentsply, Ivoclar, Diamond D, the Baltic denture system. I wish we had time to talk about some more because there's a lot more on the market now. But let's talk about fabricating a printed denture. So printed case processing. First, we want to have digitation. We're going to do case design. We do a printed try-in and the printed final denture. So we're going to start off talking about the Lucitone denture. And this is a Lucitone printed denture. And this is actually 3-shape scanner that we're using here. So we're doing order creation here. Patient's name, order number, select the second molar through the second molar, select a gingiva shade, and select what type of material you're using. And all this is going to be, and this is getting you ready to scan your impression and then scan the bite registration. So look at the clarity from the scanning of the bite registration on the wash impression on the screen here. I mean, the clarity is all the anatomical landmarks are there. So when you're designing this, it's so easy to design, and you can pick up into any discrepancies. You can really fix those discrepancies also while you're designing. And if you're doing on scanning the bite, there's a couple of different ways to do it. I don't do it this way. This is not my articulation, but I just wanted to show this picture. What we do, you make marks on the vertical wall of the model to aid in the alignment, because otherwise the scanner sometimes gets confused and it doesn't result in an accurate bite for a printed try-in. So they're going to show the E3 scanner here, and you can see the little marks here in the model. That's going to help line this up. And this is my method here. So I'll have this on the magnetic articulator, semi-adjustable articulator. And what I'll do here is just use a scan spray. I'll put it in a 3-shape scanner. I happen to be using a 3-shape scanner, scan it, and then that'll merge in with the impression that was taken, and then we're ready to do our design of the denture. And this is just a little video showing, designing a denture that was taken off put together with a rubber band, and then put those little indents on the models to line everything up correctly. So this wasn't even articulated at first. So I like to have an articulation to go back to. I'm kind of old school that way. So articulation with centric and lateral adjustments. The vertical articulator allows for central and lateral exertions, therefore saving the dentist valuable chair time and adjustments. We'll show a little video here. I think we have a little video. Yeah, here we go. So you can see the excursions here. It's going to show on this upper arch on the adjustments, and it just saves a lot of time with the centric and lateral adjustments here. And then once everything's designed and you're ready to, we're going to print that try-in now. So we're going to talk about printing the try-in first. And let me just go back here. Let's go this way here. Let's talk about printing the denture. We talked about the try-in earlier. So if everything looks good in the try-in, we don't have any adjustments on it, we're going to print the denture. So we send that information to the printer. This happens to be a carbon printer, and you can print, I think, almost 12 dentures at a time. And so we're going to scan the design, we're going to print, and we'll do something called wash and recycle. And what this is doing now, it's not fully cured. So we're taking some of those supports that we're holding this on in the printer while it was nesting, and we're cleaning up with denatured alcohol. And then we're ready to fuse our denture teeth into this denture base. And there's a few ways we can do this. I want to talk about some other technology that just came out recently with this same system. And then we finish the denture. But the thing I like about this, if you can design these dentures to eliminate any finishing time. So pretty much you really have to cut off those, supports and finish the denture. So let's talk about the printed denture base. This particular one here, there's other printed materials out there on the market, just like I mentioned. This happens to be the Lucitone one. It has original shades, original opaque, light reddish pink, and dark reddish pink. And finally, we have a denture-based material that mimics natural gingerbread, which is great, because 2 or 3 years ago, everything looked like bubblegum, and it wasn't natural at all. So we're going to set up that printer. And again, once that's printed, we have the support removal we have to take. We'll leave those supports on the lingual of the lower, but we'll take those supports on the buccal area, and then we'll clean everything up. And once we wash these and get everything ready for the denture teeth, we're going to be bonding denture teeth into this denture here. And we're going to be utilizing denture teeth with IPN teeth from Dentsply. And there's a couple of different methods out there which we can utilize. Not only with this system, but with other systems, we can actually print the denture teeth also. And now the printed denture teeth have come pretty far as aesthetics and strength, which was pretty nice, So we're using IPN denture teeth on this particular case here. So let's talk about that denture assembly. So once we have everything cleaned up, we're ready to bond those denture teeth into the base. So as far as the digital tooth selection, the 3-shape design software has a characterization points to set and to indicate the position of the retromolar pads, canine points, and ridge points. And this, coupled with the use of Pound's triangle, allows the software to pick the mold first, so there's no guesswork on picking correct mold, which is great. So we come a long way with picking out denture teeth, but still sometimes I'm not too happy with the mold that's picked every once in a while, and I'll pick it myself. So here's your IPN 3D denture teeth here. There's a lot to choose from. There's a lot of different molds that you can utilize. And this is the articulation key, and the articulation key is really important because it gives you a lot of information on the types of denture teeth on the anterior teeth and posterior teeth. And this is all built into the software. And this is why Most of the time, it can pick out a nice, accurate anterior and posterior teeth for you. And you have a lot of mold choices too. There's more than this. I just showed a few of the molds. You have 10-degree teeth, 33-degree posteriors, and a multiple assortment of anterior and upper and lower molds. So the first thing that we do, we take these denture teeth. We want to get them ready to fuse to that denture base. So this material called Fuse 1. You put it in a warming tray, get these teeth ready. And then we start bonding these into the denture base with this Fuse 2 and Fuse 3 material, which is like a liquid. So now I'll use Fuse 2. I'll put it in the denture base, and we have those sockets that are the exact size of these denture teeth, and we can bond these denture teeth into the base, like cure them for a few seconds rather, and then we do a post cure. So I usually put about 4 teeth at a time in the denture base. I post cure it. I think it's about 28 minutes in the post curing unit. Take it out and cut off those supports and smooth it out a little bit and polish it. That's it. There's your final finished digital denture. Printed denture, and there's your finished denture. I'll add a little bit more. This is not my finish. I'll add a little more anatomy and some more stippling, and I'm a little fanatical when it comes to that to give you a nice finished polished denture. But it's simple. And if anything ever happens to this case, we have a file that we can redo this case and reprint it anytime. So analog, we have that excessive chair time and adjustments, inconsistency with occlusion. I'm not saying in all the cases, but these are some of the things that we faced over the years. And on the Lucitone printed, we have reduced chair time, little to no adjustments, digital pre-occlusion technology, and that reduces occlusal adjustments. And the digital file is always available for duplicate or replacement dentures. Even if the patient breaks the denture or the dog eats the denture, we'll always have that file. We can make the exact fitting and exact denture that we need to make. And there's also something with this printed denture, they call it BAM, the BAM factor, or body activated material. When the denture is placed in the mouth with this material, the strength of the material actually increases from 1,500 joules per square meter to 3,100 joules per square meter. And that's tremendous. And that doubles the resistance to breakage. So that's a pretty cool feature right there, with this material. And more of these printed materials are coming to the market, and this where technology has come a long way with printed dentures. So let me check my time here. Doing well here. So we're going to talk about milled dentures now, and we're going to talk about a couple of different systems here with the milled dentures. We're going to start off with the Ivoclar system. Again, a simplified milled denture workflow is pretty similar to what we talked about on the printed side. The only thing on the first appointment with this, and I would like to get this also with the printed denture, is a pupillometer reading. And of course, what I like to get the pupillometer reading is when I'm contouring that birim, just give me some information I need to contour it as closely as possible to eliminate any excess chair time for you while you're taking the occlusal records. And then we'll fabricate those occlusal rims. Second appointment, you'll take a functional impression and a bite registration. So we really like you to do a functional impression and a bite registration to eliminate that extra visit. We'll scan and design and print the try-in for you. You'll try it in, tell us it looks great, and we can go to a finish, and we can mill the final denture. So same type of things. 4 appointments, we can do 4 appointments with a milled denture also. A little different procedure, takes a lot longer than the milled technology, and we'll talk about some of the features and benefits here. So this is the pupillometer. I like to get a pupillometer reading. I always like to get a pupillometer, even with the analog method. So what they do, we rest this on the patient's papilla, and it gives us an idea where the incisal edge is going to end up on the denture. And it helps me contour that occlusal rim when I'm contouring that occlusal rim with the wax rim to send it to the office. So a lot of different tools you could utilize. I wish I had more time to talk about that today, but I do a whole hour on just occlusion and on occlusal rim taking and by registrations. So this is special design CAD software, and it's for many different applications for full dentures, single arch dentures, immediate dentures, and the software is fantastic, really is. So and it's utilizing the same Ivoclar tooth library with Blue Line, Vivadent, and Phonaris 3 as we always used in the traditional analog way, and it has a full arch setup function too. So we can set up. I talked about setting up denture teeth earlier, one at a time. It takes a while to set up a denture. We can do full arch setup functions where all those teeth come into play in a virtual articulation at one time. And we can do separate adjustments too. We have exclusive clinical tools and workflow options too. And there's something called the oversized milling process, which eliminates a lot of finishing and time consumption while making this denture. So these are the teeth that are used in this Ivoclar system here, Phonaris, Vivadent, and Blue Line. Pretty well-known teeth all these years. and it's been transferred over to the digital side also. But again, you can also mill these denture teeth out of this special material that Ivoclar has also. I'll talk about that in a second. So software features. The software allows for complete control to change the shape of the denture teeth. It's also important to be able to create the ideal occlusal contacts for single arch dentures against natural teeth. So for instance, let's take this single arch dentures. We can adjust these teeth. We can widen the occlusal surface of the teeth, bring them into occlusion. And then at this point here, we mill the teeth. So we can't put individualized carded teeth on this now. We're going to have to mill this arch here because it's going against natural teeth. But there's a lot that can be done, you know. So and then the software features. We don't have to do a complete reset when a tooth needs to be removed. Removing the molars and premolars is as easy as a click of a mouse, as you can see here. So we take a look at the picture here, and look how easy this is going to be. We're going to do some extractions here. There we go. So all that is done in the software, and we can mill our denture. I love this for immediate dentures. You know, I lecture a lot about immediate dentures. I've been very successful with immediate dentures over the years. Some reason, a lot of technicians and a lot of doctors have a hard time with immediate dentures. And I like to contour the bone and tissue the right way so it's comfortable for the patient. And it's going to be easy to insert after the extractions. And this is pretty easy to do here. So I highlight the tooth. It's extracted in the software, and then do some tissue contouring, and what we used to call it model surgery. So, and we can contour the tissue. We leave some of the bone, take some of the undercuts away, and make our immediate denture. Really cool software here. So it's just, we do a lot of immediate dentures on the digital side with digital denture technology. So the pre-preparation scan is the design for immediate dentures, and it's simplified by utilizing the pre-prep scan. And it's an overlay function which allows the user to set the denture teeth using the existing teeth as guidelines. And I used to do this on the analog side. When I had a full upper, full lower, fully attentional arch that was going to be an immediate, I would take, a lot of times I would take 1 or 2 teeth out at a time. And now we can do this here. You could see here, we have this pre-preparation scan. All I do is 1 click, and everything comes into play here. And we're ready to do any adjustments we need to do, and then we can mill the denture. So some of the materials that are used for this is something called the ivory-based CAD, which is the actual base. And this is actually the ivory-based material that was used for regular analog dentures, only in a puck form. And then you have the Vivadent CAD, which is a tooth material. So if you don't want to utilize the carded teeth, you can utilize the CAD material, and it comes in various shades. And it's the same material that's utilized for the carded denture teeth. So it's a PMMA material. It's as far as the gingiva goes, and homogeneous, high density, high stability, and precision, and high impact. And the physical properties and high impact material are really amazing. It's really strong denture, and the accuracy of fit. We're even getting calls from doctors saying, don't even bother putting a post-dam in here anymore because the fit is so good, we don't need a post-dam. So we did a couple of trial cases without a post-dam. It worked out well. I like to still put a little, I might not put as deep as a post-dam in there, but I still like to put a post-dam on the upper denture. And the expansion and contraction rate on this material is so accurate. The accuracy of fit is amazing. So it comes in all these different shades. If you're going to be milling the material, it comes in various shades. And, you know, the aesthetics are great. As a matter of fact, I want to show you 2 sides here. I want you to pick out which side it is a carded teeth and which side is actually the mill teeth. And I always forget which ones. Every time I do this presentation, I forget. But just we're going to put a line down the midline here and tell me which side, the left and the right, the milled, and which is actually the carded teeth. All right, ready? There we go. Okay, so anyway, on the left-hand side, that's the mill tooth, and on the right-hand side, this is carded tooth. So really no difference. So that's why I kind of got away from using a carded tooth, and we mill these denture teeth out, and it makes life a lot easier. Especially, you could do it in 3 segments. You could do 3 different segments, or you can do a full arch. Aesthetics are great. Lower opacity, anatomical shape is great. It really looks like a natural tooth. Lingual anatomy, surface design is great. And I'm really happy with the aesthetics. And there's a full arch milling of the denture teeth here, and all we have to do is bond this into the denture base now. So there's something called a multi, also VivaCAD multi, where you can control the translucency of the anterior of the teeth. So you can just slide up and down with the precision of the puck, and you can control the translucency, which is great. because you really don't want that monolithic look on an anterior teeth. And that's what we used to get with a lot of the milled printed type of materials. But actually now we've come a long way with the aesthetics on these materials. Then we want to bond these teeth in the denture base. So there's a special polymerization system similar to what you saw previously on the printed denture. And it's a pre-dose mix. You put it in the little sockets there, you put those teeth in, and you put it in the pressure pot to cure. So it's a self-curing material. And it's milled on the PM7. And this is the program mill PM7. And the workflow we talked about earlier, scan and design. And there's something called the oversized milling process, which is it's called vestibular milling. So the base and the arch of the denture teeth are oversized. And once this is finished, it takes about 30 minutes for each. You want to bond it to the denture base, then you put it back in the milling machine, and it's finishing the denture for you. And then after about 90 minutes later, you have that nice denture that comes out with minimum finishing and polishing, and there you go. 20 minutes labor time, 150 minutes milling. So it's a little bit longer time than the printed material, but a lot of times it's personal preference. You like a mill denture, or you want a printed denture. Now they came out with all this trouble with the bonding these teeth in a denture base. They have a disc that just came out with called Ivotion, which is one disc, one milling, one denture. So everything is built into one puck. So you don't have to worry about bonding denture teeth in now. There we go. And these are just some of the different timelines. With a conventional single denture, processing time is 3 hours and 30 minutes. With the digital denture, with milling, it's 2 hours and 25 minutes. Now with this new single disc denture, it's 1 hour and 50 minutes, which is cool. Accuracy is great. Why choose mill dentures? Pretty much the same reason why you chose the printed dentures. Accuracy, few manual steps, consistency. And if you always have that file there, and you have the uniformity of thickness and thinness on these types of dentures too, which is great. And they have the monolithic strength. If you're milling these denture teeth and milling that denture base, it's 8 times stronger than a traditional analog denture. It's amazing. The aesthetics are beautiful. And I'll show you how the retention looks too. It's a mill denture base with the mill denture teeth. Nice occlusion. Doctor's really checking out to make sure everything looks good. And wait till you see when he tries to take out this lower denture. Very good. It has suction on the lower. That's how good it is. Look at that. Nice, strong, beautiful. It doesn't have to worry about eating a steak with those dentures. There you go. So there's also something you can utilize too. It's called the advanced digital denture workflow. There's a lot of different tools you could use. You're using a centric tray material with another tool that you can utilize with. It's almost like a Facebook transfer. And instead of giving you a bite registration, we print out something called a bite plate, and you can take a Gothic arch tracing record, and that's a little more in detail. And with that information that we have on the UTS CAD, which you see on the upper picture here, it's almost like a Facebook, only you're taking a pre-bite registration and a centric tray. And those measurements on those instruments, all of those measurements are going to be entered into the software, and it's going to make it the design a little bit easier. So once we get the information, the functional impression, the bite registration, you can utilize that, or you can utilize the 3D bite plate for a Gothic arch tracing type of registration. And we do the same thing. We scan and design, print or mill, and then we try it in and we finish it. So again, we have a lot of different centric trays, preliminary jaw relations. The UTS CAD, it actually defines the campus plane and bipupillary line. And the 3D bite plate, that's optional. So it's a naphthometer CAD. It's a centric tracer or Gothic arch tracing device. One of the most accurate ways to produce occlusion over and over again on a patient. There's your centric tray, UTS CAD, the patient's bipupillary line, And so I can't have time to get into this everything today, but these tools are available. And you can utilize the bite plate. As you can see here, this is printed and everything goes together easily. And all the tools come with it that you can take that Gothic arch tracing bite registration. That's called a nathometer CAD. Here we go. So a lot of tools to choose from. You take all that information that you took with all these tools here, put it on the RX form. We'll put it in the software and we can design a nice, accurate denture for you. A couple more things I want to talk about. I have about, I got about 3 or 4 more minutes here. This is one of the first digital dentures I ever made. And this is with Key Mill from Keystone Industries. And this is a puck that I utilize in a milling machine. And I utilize a library of teeth. I think these are Vita teeth. And I actually bonded these into the denture base. But this was beautiful. This is a scanned impression. I think I have some photos here. Yeah. So this is the final. This is a scanned impression and a milled denture utilizing, these are Vita teeth on here. So this came out beautiful. This was one of my first full upper and full lower digital dentures that I made. Pretty cool. And then we have Sterngold. It's a Baltic denture system. It's their own software. And this is a great system also, you know, and this is a milled puck, which is everything's in the puck. You don't have to worry about bonding denture teeth into these pucks here, but you can, the software, as you can see, has many design options. Like I showed you this earlier with the design, with scanning the bite registration. And the teeth and denture base are fused into one milling puck, and that prevents separation. It's a one milling process. Look how nice, those teeth are never going to break off. I mean, you can see the bond to that puck. Different sizes, small, medium, large, Vita shaded teeth, narrow, medium, and wide arches. And you also have like a darker shade, like ethnic shade, and then you have a pink shade. So there's 60 points of measurements on the intaglio surface for more accuracy and a better fit. They have their own software, the Baltic denture system. As you can see here, this is milling the final denture here. So I said, milling takes a lot longer than printing, but there's your nice finished denture. Look at that. Beautiful. Now, this is a great system also. And also when it comes to implants, you know, we could utilize digital technology on digital dentures with implant dentures also, you know, using CAD design. This is called Creator Plus with the Baltic denture system. And this is usually utilizing locator attachments. And I like the locator attachments also because we're able to utilize scan bodies, you know, so those scan bodies for, you know, for those locator attachments are great. Any overdenture cases, you can scan and mill out that base to go over that denture, those attachments. You can either loop them in the mouth or cure them in the mouth, or we can do it in the laboratory. And there's your locator scan bodies. This is so much easier than, you know, trying to take an impression and do guesswork and luting these in the mouth. We can do this for you in the laboratory. And I love these scan bodies. They're so accurate. They're so accurate, as you can see here. Everything's designed on the software. And then we can also utilize printed technology for hybrid transitionals. This is something that, you know, we utilize a surgical guide. So this is a whole other course that we do, but just to show you what, you know, all those access holes are drilled beforehand. So when you're doing your denture conversion for a hybrid denture, for that temporary denture, it makes life a lot easier. You know exactly where those access holes are going to go and where those temporary cylinders are going to be cured. So all that we're utilizing is that surgical guide, and then printing out the denture teeth and the denture base for this transitional denture. So some of the special considerations, we have to consider the restorative space of all the materials that we talked about, you know, the abutments, the hybrid bar, the space, the acrylic teeth, and the acrylic and the teeth, and the space between the tissue and the bar. So we want to make sure we have enough room when we're doing that final restoration, at least 12 to 15 millimeters of restorative space. And if you look at the relative functional jaw capacity, the lower jaw, with a lower denture, it's only 10%. We could talk about an overdenture, it goes up to 60% functional jaw capacity. And with an implant screw retained denture or bridge, 90%. And it's made all natural teeth, of course, are 100%. So we have another course that we do on implant dentures that stay tuned for that in the future. But with that, you know, we also have to look at the transitional line, the junction between a natural pink and artificial pink, the mobility, the smile line, the amount of bone, everything has to be taken into consideration. And all this can be designed on with digital technology. And we have to still follow the protocol, the correct protocol in making these dentures also, from the preliminary impression to the verification index, the complete setup. And then we have this, we send it out to get milled. and we do another try-in after the bar is milled, and then we finish and process. So just follow that protocol. You need to follow. Don't take any shortcuts, and you'll have a successful case. Can we make a better denture? I believe we can. I think we can make a more predictable denture. And the communication between the clinician and the digital denture technician, can only make it for a successful case. So advancement in denture technology, we've come a long way. It's still an evolving technology, and we're going to see a lot more in the future. But I want to thank everybody for joining us tonight. And our ultimate goal is to achieve that ultimate goal of patient satisfaction, and that's what we do at NDX. So thank you, everybody, for joining us tonight. If anybody has any questions, I'll be glad to try to answer them. But again, thank you for joining us tonight. Really appreciate it. And here's my information here on the screen, durban@dentalservices.net. If you have any other questions, you can always email me, and I'll get back to you with an answer.